Good morning and welcome to this Oncology Data Advisor interview. Today we're having this discussion in honor of Brain Tumor Awareness Month, Go Gray in May, and I'm joined by our two guests, Dr. Morana Vojnic, who is the Director of Neuro-Oncology at Rutgers Cancer Institute, and Dr. Jonathan Sherman, who is Chief of Neurosurgical Oncology at Rutgers Cancer Institute and Robert Wood Johnson Barnabas Health. They're here today to share their perspectives on updates in brain tumor management and perspectives on the Awareness Month. So I'm excited to talk with both of you today. If you'd like to start off by a brief introduction of yourselves and what you do.
Of course, yes. My name is Morana Vojnic. I'm the director of Neuro-Oncology at Rutgers Cancer Institute and system leader for Neuro-Oncology for Robert Wood Johnson Barnabas Health. I'm a medical oncologist by profession, and I treat brain tumors.
And my name is Jonathan Sherman. I'm the Chief of Neurosurgical Oncology for Rutgers Cancer Institute and also Professor of Neurosurgery for the Rutgers Robert Wood Johnson Medical School. And so my primary role is as a neurosurgeon in treating brain and spinal tumor cases with patients that need a combination of care for medical radiation and oncology and neurosurgery. So I help quarterback those patients across the spectrum. And so that's kind of my role, both as a neurosurgeon and as the chief of service.
Amazing. Looking forward to hearing both of your expertise today. So, Dr. Vojnic, we can start off with you. Would you like to tell us what updates in brain tumor management have occurred recently, especially over the past year?
Yeah, thank you, Kira. So, Brain Tumor Awareness Month always comes with a grain of salt for us in our field because there are always a lot of things that happen and exciting things that happen, but not as many as we would like. So, over the last year, there have been those quite a lot of advances in our field, specifically when we look at medical oncology management on brain tumors. We have had the FDA approval for the IDH inhibitor vorasidenib for the treatment of IDH mutant low-grade gliomas. In addition to that, we have had some other approvals, particularly also in pediatric neuro-oncology. The drug tovorafenib, which is a BRAF inhibitor, was approved based on the Firefly study, which looks particularly at pediatric patients with low-grade gliomas who had a BRAF alteration, so a fusion or V600E mutation, some sort of other mutation, and had a recurrent low-grade glioma. So treatment with tovorafenib did harbor an overall response rate of about 50% with a duration of response of 13.8 months. In addition to that, we've had another FDA approval for a drug specifically for NF1 and plexiform neurofibromas, non-amenable to other treatments with mirdametinib. And there were other studies that were published and actually results of them for the treatment of H3K27 and mutant gliomas. It's currently still an investigational agent. The agent is called ONC201. So the H3K27 gliomas are a notoriously hard to treat disease. They're like a WHO grade 4 glioblastoma, but typically they don't respond to standard of care therapies that well. So it is very encouraging that we have an investigational agent that seems very promising. And in addition to that, there were some studies published that showed another agent called brigatinib in NF2-related schwannomatosis. So overall, not as much as we would like it to be, but still very promising and encouraging that things are happening in our field, and we might have even more things in the future. And I want to take this opportunity now to perhaps ask Dr. Sherman. Dr. Sherman, what are some of the surgical advances that has happened over the past year in the field of brain tumors?
Yeah, so fortunately, with the world of neurosurgery, we're very locked in with our researcher colleagues as well as the companies out there that have novel treatments to help improve the outcomes of our patients. So we have a lot of different things that we have access to, and so one of the biggest things that has come into play is is a phrase called oncofunctional balance. Like really, how can we maximally resect a tumor with minimizing any deficit or problems for the patient? So they actually, if in an ideal world, would be the same if they as they are pre-op to post-op, if not improved. And so there is a program that works with the human connectome. So the human connectome project worked with the networks in the brain. And we used to really only focus on two major issues. One was ability to move, like the motor, the corticospinal tract, the motor areas, and the ability to speak. And we know now is that there's 7 major networks. They include things like the default mode network and the central executive network. These are things that allow us to actually be aware, and then also when we're not as active, be able to still process things. And so we're integrating that into the pre-op setting for surgical planning to minimize damage to these networks. And then we integrate it into our, we have a navigation, it's like GPS for the brain, and we can actually navigate. We've been doing that for years, but now we can incorporate these constructs of essentially the parcellations, the areas of the brain that are associated with these networks, and then the fiber tracks where those connections on the surface of the brain connect into the highways going into the brain, the diffusion tensor imaging, the fiber track. So that's one area that we're working. We're integrating neuropsychology more readily into the OR to kind of correlate our tests that we do with these networks. So now we can have a neuropsychologist preoperatively assess a patient, and we can figure out. Before it was very rudimentary. There were only certain things we were testing. Now we have a spectrum of tests that we can provide to patients, and then we can incorporate that in the operating room, where we're actually traditionally we would be very selective on what we might do even for awake brain surgery, because we were only testing certain things, and maybe it was just speech. Now we're testing out these paradigms for these networks, and it can be on, essentially for all intents and purposes, any patient that can tolerate an awake surgery, and most patients can. There are certain patients that we rule out for that type of thing, but we have a whole paradigm on how we do that. And those patients can actually then get pre-op testing. We can determine what we want to test. Then interoperatively, most patients could be eligible for that. And then post-operatively, we can show that we've preserved those functions. So that's one thing we're looking at. We've integrated novel fluorescent guided drugs, fluorophores, so that the tumors that can look very malignant brain tumors can sometimes look very much like normal brain, especially when we get to the edges. The tumors have those fingers that kind of spread to the adjacent normal tissue. And so we're integrating drugs like Gleolan, which is kind of the kind of becoming a standard, where the tumor itself will light up as pink under a blue filter. And so we can integrate that into the surgical plan. And then we can get a higher degree of resection, taking into account that oncofunctional balance to maximize resection. So that's another thing. And then we also integrate things like augmented and virtual reality that we can help plan out surgeries better, using reconstructive images, so we can see the imaging with 3D reconstructions. We can use that in the pre-op setting, show patients that they have a better understanding. We feel that patients, if they better understand their tumors and have a better disposition and understanding going into surgery, they do better. There's literature that supports that. So then when they're in the OR, then we're actually navigating and using our navigation software, but using it in a virtual reality or augmented reality setting. Virtual, where we have a virtual environment around us; augmented, where we can see the world around us, but actually can augment the imaging of tumors, and that can help us in a lot of ways. So those are some of the things that we're integrating. But as I said, the world's our oyster in neurosurgery. We have so many companies that reach out to us on a daily basis, and it's just picking the right ones to help benefit our patients.
And just to pitch in here, are these things and these technologies available throughout, let's say, the United States, or are we focusing more on these are more academic institutions that would have these kind of technologies?
Yeah, there's a lot of push for for smaller hospitals that traditionally would always be in a community referring to the academic center to keep those patients. And many of those hospitals do a great job. That being said, I think that it's kind of like the old days of vascular surgery data, like saying, all right, if you do 1 aneurysm a year, are you doing as good as a center that's doing 10 or 20 aneurysms a year? And there's a number that comes out that says, all right, if you do on average these number of cases, you're going to do better. Your patients are going to do better. So I think that when, the high volume centers are typically the academic centers that are seeing these patients. So, you can get, depending on where you are, you can get these things paid for. Some are very inexpensive. Some like the virtual and augmented reality systems can be quite expensive. And so if you're only seeing a small volume of patients to start with, it might be more challenging to get those systems into those hospitals. So I think on average, the combination of all these technologies is more readily available in the traditional academic center. And then we're seeing a higher degree of volume of those patients anyway. So as you use these technologies, you there's a certain learning curve to saying, how am I actually using this to benefit my patient? And am I maximizing its use? So I think in the larger academic centers, we have more access. First of all, we have more patient volume on top of that. So we get really subspecialty advanced care that I think is still better at our major academic centers. And for those patients, you're going to get a better potential resection, meaning quality of life is maintained because we're doing these things. Like I was in a smaller hospital before I joined Rutgers, and we had trouble finding a neuropsychologist that we could hire because that level of volume didn't support them coming on board. And so getting that level of care at that smaller hospital was hard because we couldn't hire that person I needed. It wasn't even a question when I came to Rutgers. So that, we have that person brought on almost as soon after I started. And so we're building that program. So I think it's just easier when you once again have the volume to support the onboarding of those types of technologies and clinicians to help you build a program.
Thank you for that. And another question I had is, can you speak perhaps on your perspective on the role of LIT or laser interstitial thermal ablation in brain tumors in general?
Yeah, so laser interstitial thermal therapy is a concept that was decades old. The idea is you put a laser diode into the brain and you can heat to a certain temperature and you can ablate the tumor. The problem was that we needed really MR thermometry, the MRI scanner, to come up to speed to be able to give us an appropriate temperature designation, so we can say, all right, this is our limits, and we can pre-specify those limits that we don't want to injure. We don't want to have outside of our tumor reach a certain temperature, and then we can specify what the temperature we want to have in the tumor. So that data really had to come to fruition, and really over the last, I would say, 8 to 10 years, that's come in vogue. And so the question is, when do you do it? So essentially, you have primary tumors that you can burn those tissues. The tumor cell death that you get from the laser ablation causes, there's two types of edema, swelling in the brain. There's vasogenic edema, where the tumor actually generates the fluid. With tumor death, you get cytotoxic edema, and that can actually be worse than the vasogenic, and it can be quite significant. So if you already have vasogenic edema from a tumor being there, emitting this fluid into the brain and puts pressure on the brain, suddenly you burn that tissue, and if it's big enough, you can get a significant cytotoxic edema effect that can actually be detrimental to the patient. So when it was first started, there were people using this a lot in various different tumors, and we've become more selective as time has gone on. So I think that now the cutoff is, some say 2 centimeters, some will go up to 3 centimeter maximum diameter of a tumor, and say beyond that the edema risk is high. The first patient I ever used this on was for a malignant brain tumor. It was deep in the brain. It was in the brain stem. And it was this relatively small tumor with no edema. And but even burning that tissue, and the patient did very well after a recovery phase, because they talk about it, well, you can go home almost the same day. Well, that cytotoxic edema caused the ventricle system to be for the short period obstructed because the brain swelled and it blocked these pipes, the ventricles, and the patient needed an external ventricular drain for about 3 or 4 days. And then we were able to remove it, and the patient did fine. So we have to take that into account. So I think we have seen there's a lot of data that shows you can do it. The question is, when should you do it? So we think that for upfront treatment, maybe not. We think that if there's deep area of the brain that you can do some resection, maybe there's part of it that you couldn't get to safely from an angle that you were working. Maybe we can do a laser at the end of that. A lot of times it's for, all right, you've treated it a primary brain tumor like a glioblastoma. Now there's a small area of recurrence. You can put the needle in, you can do a biopsy and then laser ablate that. You have a patient that's had a brain metastasis that's been radiated, now it's growing. You can actually put a laser in if it's an area that maybe isn't, to minimize, it's less access, it's a small stab incision, and you can use it for that kind of case so that you can burn the tissue. You can do a biopsy proving that it's radiation treatment effect or actual recurrent tumor, and then you can burn that tissue to get an effect. So I think that we're really now figuring out the selective role for this type of modality.
And yeah, thank you for that. I think it's also very interesting and important to note this, that nowadays, even in oncology or in neuro-oncology, we also have techniques where we try to perhaps even diagnose patients or see if something is true tumor growth versus nothing else non-invasively. We even have assays that we can sometimes use blood-based that are approved or commercially available, that where we can just, with a blood draw, we can sometimes try to ascertain if there is a mutation from an initial primary tumor present in the bloodstream. So like we do it for all other cancers, now we're even starting to do it in more and more for brain tumors, which is even important because while we have very talented neurosurgeons around, like Dr. Sherman, nobody really wants to undergo an invasive procedure if it's really absolutely not necessary. So we have all sorts of techniques where we also can try to discover these certain mutations even in the bloodstream or even in the cerebral spinal fluid, and perhaps even based on that, decide how we can treat these patients, which we have very challenging diagnosis and a big impact on their quality of life.
Yeah, Dr. Vojnic, where do you feel that the liquid biopsy, like where do you foresee that going as being a critical part or lesser part of our armamentarium for diagnosis and treatment?
Well, in an ideal world, and my dream would be that we would be in brain tumor management the same, even better than we are in metastatic cancers, where in metastatic cancers, it started off with a few cancers, but now it's pretty widespread and wide use where we use these liquid biopsies, blood-based assays. And in brain tumors, we basically just started it. The problem is a lot of the things that happen in the brain remain in the brain. So it's not like any other type of tumor or cancer that spreads throughout the body and into your brain. It's actually vice versa and stays in there because it's a sanctuary site. We know the brain and the spine is a sanctuary site, and it really is trying to protect your life and the way you function, which is a good thing. But on another thing, it's very difficult to diagnose because of these things that you really need invasive procedures typically. So now there are assays available out there where the sensitivity is not as great, let's say, as with any metastatic cancer, which is logical because there's not so much tumor shedding or even DNA shedding from the tumor. But we can use them if perhaps there is a very difficult area to access. And now it's not 100% certain. It's not even in our guidelines, but there are providers who are using these assays, especially when there is no other option available. So in an ideal world, we would have all of that in the guidelines. We would have all this in our armamentarium with things we would be able to use, and we would be able to decide based on a blood test what kind of pill we can give a patient. That would be an ideal thing. Unfortunately, we're not there yet, but I remain hopeful that we're going to be there, especially with all the FDA approvals that happened in the last 12 months, especially in the brain tumor world, and hopefully we'll have more in the future.
And one more question I have for you is a long time ago, I listened to a lecture by Judah Folkman, who passed shortly after that, and he was the founder, or he identified VEGF in his research. And you know, we have bevacizumab as a treatment. You know, it's air quotes because of what it actually does, and we're still working out the nuances of what it does. Where he described that the treatment for these malignant brain tumors is going to be multimodality. It's going to be different types of treatments or different types of drugs affecting different pathways. How do you foresee that really it's evolving to really that type of you know, treatment paradigm where we still are very much, you know, we're doing the vaccine trial, we'll do immunotherapy, we'll do, you know, chemotherapeutics that are cytotoxic. How do you see that transitioning to that or ever going into that world that he described?
I think that's an ideal world, and that's a dream where I think we should strive getting. The reality is, and I keep saying this, but the reality is with all the other cancers that we treat them with multimodality therapy. We give two chemotherapeutic agents plus an immunotherapy, all given at the same time. In brain tumor management, we're not there yet. There are definitely trials ongoing. There are definitely investigators with a lot of great ideas, and even investigator-initiated trials that are ongoing. However, we're not there yet where we have really a regimen where it's a multimodality treatment, except for example, our standard of care PCV, so 3 different chemotherapy agents we use for oligodendrogliomas. But that is where we should be striving to get there, because we know every single tumor, there is tumor heterogeneity. So there's different tumor cell types. One will respond to one thing, the other one will respond to another thing. So it's very too idealistic thinking that you are going to give only one drug and that one drug is going to really shrink the whole tumor and make it go away. The reality is we probably need to use multiple different agents at the same time to attack different pathways that these tumors and tumor cells are really expanding upon. We're not there yet, unfortunately, in our field, but hopefully we'll be there one day.
Thank you both so much for these updates. It's so exciting to hear about these technologies and the FDA approvals and all the reasons for patients to have hope. So last question for you as we wrap up is, since May is Brain Tumor Awareness Month, what message of awareness or any wrap-up messages for both clinicians and patients would you like to share to drive home the point that there is hope in this field?
From my perspective, really, and this I think is really key for patients and their relatives, keep reading, research your information, ask people you know who've been through your type of situation. It's okay to get second and third and fourth opinions. It's okay to ask as many people as you can. The reality is standard of care is the same everywhere. Clinical trials, investigational agents are not, but it's good to really do your homework. So don't be afraid to ask. It is your right to ask. And don't be afraid to do your homework, because there's a lot of people out there who are willing to help. And there's a lot of clinicians out there who are going to even send you to another clinician if they think they have something that they are not able to provide. So we're here to really improve our patients' quality of life and longevity.
Now, I'd say from my perspective, well, I think we're really on the cusp here. I mean, the advances, especially in malignant brain tumors, for all intents and purposes, haven't been enormous in the respect of we're not at a cure yet, but we have shown survival benefit where patients are living longer now than they were even living 5 or 10 years ago. But I think we're on the cusp. I think we're, with all the different avenues that we're looking at, especially on the surgical side, with trying to maximize surgical resection with minimizing any morbidity and improve and maintaining and improving quality of life. I think we're really hitting the heart of understanding the brain to a point that we can really benefit our patients. And even to the point that if patients have problems afterwards, we have ways, which we didn't even get into today, of providing treatment to help alter plasticity, changes in the brain pathways, so that the patients can use other areas of the brain that might not be active until we activate them to improve their quality and function in life. And so I think we're really on the cusp. And I think so this is where major academic centers are pushing the needle. And so our goal is that the oncologic treatment can be across the board, even in smaller hospitals. We're not there yet, but we want patients to not have to go travel around the country or the world to get their treatment. And so I think as we build these out in our academic centers, it's going to spread out to our smaller hospitals, and really with the ultimate goal of, your neighborhood hospital can provide the best level of care. So, it's a long burn. It's not a short burn with these type of things. But the exciting thing is I think we're really making some strides over the last 5-10 years, and I look to see that in the next 1 to 2, 3 years to see some major outcomes that we're seeing in the from bench to bedside, from the lab and the clinics to the post-op area, and the survivorship, and really having a heavy burden of patients going to our survivorship conferences because they're long-term survivors of this devastating disease.
Absolutely. Well, this is fantastic. Thank you both so much again for coming on to share these advances and all the hope on the horizon. So really appreciate your insights today.
Thank you.